Greetings to one and all. I am Dr. Amrita Gopalan, DNB final year resident from KIMS Secunderabad. Today I will be presenting a case, a non-COVID cytokine storm. Our patient is a 22-year-old female and engineering graduate from Hyderabad. She presented to the Department of General Medicine with history of intermittent fever since 2 months, intermittent erythematous skin rash over her trunk and extremities since 2 months, acute onset right upper abdominal pain since 3 days. On examination, there was pallor, icterus, generalized lymphadenopathy, a diffuse erythematous maculopapular rash over her face, trunk and extremities, hepatosplenomegaly and right hypochondriac tenderness. Her investigations at admission showed a normal blood count, high inflammatory markers, deranged LFT with a bilirubin of 1.9, AST was more than ALT, creatinine was 0.4, urine routine showed trace protein with microscopic hematuria, 3 blood cultures from peripheral sites were negative and her urine culture was negative. Her 2D echo was unremarkable. Her CECT chest and abdomen showed generalized lymphadenopathy, hepatosplenomegaly, bilateral pleural effusion with mild ascites. Over the next 10 days in the ward, there was a gradual drop in her hemoglobin, a rise in the total leukocyte count, a gross derangement of her liver parameters. Bilirubin rose from less than 2 at admission to over 10. Liver enzymes continued to fluctuate above 500. Extensive infective and autoimmune workup was done by the treating team. All the reports were negative. PET CT showed hepatosplenomegaly with generalized lymphadenopathy with low SUV uptake. Cervical lymph node biopsy showed reactive lymphadenitis, and bone marrow aspiration and biopsy was normal. After 10 days of hospitalization, patient was referred to rheumatology. In view of fever, rash, leukocytosis, hepatosplenomegaly, lymphadenopathy, serositis, jaundice, and negative rheumatoid factor, negative ANA, she was fulfilling Yamaguchi's criteria for the diagnosis of adult onset Still's disease. In view of the significant hepatic dysfunction, we worked her up for macrophage activation syndrome. Ferritin was high, there was a drop in ESR from 48 to 8, AST was high, triglycerides were very high, and serum fibrinogen was very low at 99. We finally came to a diagnosis of adult onset Still's disease with macrophage activation syndrome. This slide shows us the course of events over the next 2 weeks in the hospital. Patient was started on IV methylprednisolone 1 gram per day for 5 days. After the 3rd day of pulse steroid, she became afebrile. However, she started developing pancytopenia, her liver parameters worsened, and serum ferritin jumped to over 17,000. Hence, we added second-line agents in the form of cyclosporin 50 mg twice daily and gave her 1 dose of tocilizumab 440 mg. Despite these measures, patient's cytopenias and liver parameters continued to worsen. Her ferritin rose to above 35,000 and clinically she developed hepatic encephalopathy. At this point, the further options in front of us included cyclophosphamide, etoposide, IVIG or anakinra. Keeping in mind the safety profile of all of these agents, we chose IVIG and she was given 120 grams over the next 5 days. Patient's count stabilized, her liver parameters stabilized, and her serum ferritin dropped to 937. Patient improved symptomatically and she was discharged. On follow-up over the next 3 months, her steroids were tapered and stopped. She is currently on cyclosporin once a day and doing very well. Moving on to a brief review of literature on the subject. Broadly, 2 phenotypes of adult onset Still's disease have been described, the systemic form and the articular form. The systemic form is characterized by high interleukin 1 and 18, hyperferritinemia, high interferons. There is a higher degree of autoinflammation and NK cell dysfunction, which leads to high fevers, serositis, hepatitis, and HLH in these patients. On the other hand, the articular variant has a predominance of interleukin 17, 23, and TNF-alpha. There is lesser degree of autoinflammation and NK cell dysfunction. Hence, these patients have less systemic symptoms and more arthritis. A patient can be said to have refractory Still's disease if there is insufficient clinical response to corticosteroids and methotrexate. It would help to declassify these patients as the systemic form or the articular form. Patients with a systemic phenotype would benefit from anakinra followed by tocilizumab. On the other hand, patients with articular variant would benefit more from anti-TNF therapies. In patients who have complicated situations like hemophagocytic lymphohistiocytosis, myocarditis, coagulopathy, or diffuse alveolar hemorrhage, other agents which can be tried include IVIG, cyclophosphamide, cyclosporin, and plasma exchanges. The incidence of MAS in Still's disease ranges from 1.5 to 4.7%, and the mortality of these patients ranges from 8 to 22%. Factors predicting poor outcomes in such patients include the presence of hepatitis, lower fibrinogen levels, anemia, thrombocytopenia, and the male sex. Treatment of MAS secondary to AOSD, the experience is mainly from primary HLH or MAS complicating lupus. Evidence for therapy is only from case reports and series, hence there is no consensus on how to treat these patients. The aim is for immediate and profound immunosuppression. 70% of patients with AOSD and MAS will respond to steroid monotherapy. Additional 20% will respond to a combination of steroid and cyclosporin. A 10% group of refractory MAS, agents like cyclophosphamide, IVIG, anakinra, tocilizumab, and etoposide have been reported to be efficacious. In conclusion, the take-home messages from this case are: two phenotypes of adult onset Still's disease are there, the systemic form and the articular form. Early identification of MAS is key. Decrease in ESR may be an important clue. First-line therapy in these patients would be steroids with or without cyclosporin, and add-on therapy in steroid refractory MAS, the decision will be on a case-to-case basis. With this, I would like to conclude. Thank you for your patient listening.